The history of the National Health Service started in the United Kingdom, and it is of that organisation, which was established after a century's discussion on the provision of health service, that met a long recognised need. It appeared at a time when Britain saw healthcare as crucial to one of the five giants that Beveridge, in his wide sweeping report, declared should be slain during the post-World War II reconstruction. That is, want, disease, squalor, ignorance and idleness. The cataclysm of war provided an opportunity that might not have been taken in quieter times, and Beveridge's plan encompassed care, to use his words, by the state from cradle to the grave, with healthcare free of charge at the point of supply. The NHS was a noble conception, and it has been faced ever since, on the one side with ever-increasing costs as a result of advances in medical knowledge, medicines and technology, and on the other with the financial restrictions inevitable in a centrally funded service with changing management dogmas and political beliefs. Whether knowing what we know now, whether we would have followed the same path towards a universal healthcare system is anybody's guess. But the initial 1946 UK legislation, the detail of which was enacted into Manx law, specifically stated that it was the duty of the minister to promote the establishment of a comprehensive health service designed to secure improvement in the physical and mental health of the people and the prevention, diagnosis and treatment of illness, and for that purpose to provide or secure the effective provision of services. The first UK Minister of Health was Aaron Bevan, and within 12 months he was saying that demand had outstripped the facilities and also the money available. Well, the legislation may have undergone some significant change in the passing years, but those basics remain today, bringing with them increasingly complex patient needs and an unrelenting demand on all of the health services. The Isle of Man has been running multi-millions of pounds over its allocated budget for some years and is currently undergoing yet another review of its services and finances. Alongside of this, the whole operation of Nobles Hospital has been under independent scrutiny, and the last of a series of reports is due shortly. And also a recent UK report has set precedents for the way the hospital is operated. Well, to discuss the Isle of Man Health Service in general and the pressures on it, we welcome, as our studio guest today, the Minister of Health and Social Care, North Douglas MHK, David Ashford. Thank you for joining us, David.
Good afternoon, Roger.
Well, when we look back, of course, the problem of getting the books to balance is not a new one, is it?
Well, certainly in the UK, you referred to it there, the first year of the NHS in operation in 1948, they were 140 million over budget, if I remember correctly, at the end of that first year. And as you say, Owen Bevan was very quick to say that demand had outstripped the resources available.
Yes, partly here, but he who forced the thing through as well, of course. That's the thing in politics. Is, if you speak up about something, you get the job. Now, soon after you taking up the role of minister, how long have you been in the job now?
It's just over 2 months, so about 2.5 months now that I've been in post. It's obviously been a very quick learning experience. It's a huge department to try and get to grips with, but I must be honest, I've enjoyed every minute of it so far.
Right, but you say huge department. I mean, we're talking about really two departments rolled into one, aren't we?
You are. I mean, health and social care, but I think it's very, very important that the two are together because you do have overlap between both the social care side and the health side. And in fact, the UK has just recently followed the Isle of Man's example, and Jeremy Hunt has become in the UK the very first ever Secretary of State for Health and Social Care.
Well, I've seen it being on its own, put together, on its own. It's been a divorce and joining arrangement for quite a while. This latest one was only a few years ago, wasn't it? 2 or 3 years ago?
It's about 3-4 years now that it's been combined up. But I think it is important because I think there is so much overlap. We talk about government silos, and certainly myself over the years has talked very much about breaking down government silos. And if you haven't got the health and social care elements working together, then you have got a very disjointed system.
Well, soon after taking up your role as a minister, so this is pretty recent, you said that a review is crucial. Now, I never quite understood what you meant by a review. What was the target of it?
I think very bold and very ambitious. It was a complete holistic review of the health service. I think we do need to look at what we are delivering and how we are delivering it. I said very clearly in one of the very first interviews I gave when I became minister that I believed that it wasn't just looking at the finances, it was also looking at what we deliver as services and how we deliver those services. I'm very keen that we start moving more into the community. We have a 5-year health strategy that came into place when the now Chief Minister was Health Minister, and I think we should be pushing forward and delivering on that. And to be honest, over the last year and a half, I don't feel there has been much delivery on that 5-year health strategy.
Well, you did say as well that you thought the performance was unacceptable.
I did indeed, and I stand by that. I think at the moment there is a lot of efficiencies to be made, and I again want to make the point efficiencies doesn't mean cost cutting. An efficiency is where you do something for less money but provide the same service, and I think there is a lot within the Department of Health and the social care side where we can achieve more.
Well, leaving aside the services, we'll come to that in a minute, because what people expect, and especially in today's environment where every month new treatments and new facilities come on the market for people. But we seem to be focusing a lot, particularly in Tynwald, not on the service but on the money.
I mean, obviously that is a concern because, I mean, I've said again in the last couple of weeks that if the health service eats up more and more of government's budget, then that's less services government can provide elsewhere. I made very clear that, I didn't believe that health should be a burden to other departments. There's other departments such as education, DOI, that need funding just as much as health does. And it is a duty of me as health minister, and I think of everyone working within the health and social care sector, to ensure that every pound of taxpayers' money that does go into our system is spent wisely.
But the failure to stay within a budget, Buchanan said that in fact that was the bit that concerned him the most. But nevertheless, I would have thought with health it's almost impossible to anticipate the demand.
Obviously, being a demand-led service, there is issues around that, but I think also there's a lot of stuff that needs to be done structurally. I think very much at the moment we are an old-fashioned service that focuses on treating people when they become ill, and I want to see more of a wellness service, to quote a phrase. I think we should be moving away from being a sickness-led service to being a wellness service, treating people in their own communities outside of a hospital setting, and ensuring that we try and do preventative medicine more.
Well, now, the need of a health service, therefore, you're talking about one that now meets more modern-day demands with a more modern concept of it. This prevention better than cure is not a new idea, but to use your point a minute ago, does seem to have been put on the back burner a lot. Not entirely, but not as a priority.
It does, and I think the reason being that, I'm going to be bluntly honest, I think there's been a lot of firefighting in the department. I think they've been so busy, fighting on the acute side and using the budget to stabilise things there. They've not been able to progress the advance in community care in ensuring people do stay in their homes longer and that people are treated in their own homes and in their own communities. And you've got to get it to a point where you draw a line and say, well, actually, we do have to bite the bullet and transfer some of the money that's on the acute side into the community care.
Do you think the problem may be not just what's been going on, but the fact that the whole funding model is not suitable either to the service it provides?
I remain to be convinced of that. I mean, I probably became the first health minister ever to stand up in Tynwald and not turn around and say the health service is underfunded or we need more money. I'm still not personally convinced that the budget we have is inadequate. I still need to be convinced of that. I just think that there's a lot of inefficiencies in the system and that we need to be looking at how we are spending the money and the areas we're directing it to. As I say, a lot of firefighting seems to go on where we seem to be treating people once they have become ill rather than picking them up early on and trying to prevent them becoming ill in the first place.
You use the word firefighting. I've heard it said also a lot of infighting. Which various people, coming back to a sort of a lesser stage in the budget, are pitching for funds for their own department. There's a certain conflict occasionally within the system itself.
I mean, obviously, I've only been a minister for a very short time, but I can honestly say I haven't actually seen that. I haven't seen evidence of that. In fact, all my colleagues in council and ministers have been very supportive of me.
No, I didn't mean within Tynwald. I meant within the structure of the hospital, within the structure of the health service.
Again, I haven't seen evidence of that, to be perfectly honest. I've found very much, particularly when I've met with senior officers, that there really is a will for them to work together together to try and deliver a better service. I think there is a recognition amongst the senior officers in health and social care that there is an overlap between the different divisions. So mental health can overlap with the acute side, the public health side overlaps with mental health as well, and the officers are trying to work together to make sure they have a joined up approach.
How will any new independent review help with all this?
I think the issue at the moment is, again, just coming back to the firefighting, obviously the senior officers within the department have day-to-day tasks that they have to undertake. And I think sometimes it's helpful to have someone outside coming in who can take the time to analyse what is going on and actually suggest how things can move forward. Sometimes the old phrase of you can't see the wood for the trees. And I think it's a bit of that sometimes. And I think with an independent review, we will be able to get a proper look at where the money is going, how the money is being spent, and equally how the services are being delivered, and are we delivering value for money?
And is that in place yet?
The review, there'll be an announcement within the next week or so. Watch this space, basically, Roger.
Yeah, okay, so it's about ready.
It's about ready to go.
Right. Now, the West Midlands Quality Review Service, which is in its latter stages, one more to report in the number of reports that they've made, it's nearly complete. It was more focused on quality, not on necessarily the money. But it must have contained some financial references on the way.
It did. Obviously, there was issues around certain services identified. I said in the House of Keys, in answer to a question from Mr. Hooper only this week, that there were about 700 different work streams if we wanted to progress everything across the West Midlands reports. Again, the West Midlands Quality Review has, I think, been exceptionally helpful to the department because they have been a very good critical friend and they have identified things where we do need to take action, and the department has been taking action in those areas.
I find it difficult sometimes to work out what's going on where, because you're talking now, we've got the West Midlands report, we'll come to another one at the moment, which are adopting the provisions of a UK report. You've got the Public Accounts Committee at it. There's all sorts of people looking at this at the moment. But if we go back to the West Midlands Quality Review Service at the moment, they raised concerns, and other people raised concerns, going back to 2014, and it would appear from their current reports they're not yet fixed.
I think what you're referring to is around the issues they identified in terms of governance.
Yes.
There is a lot in the pipeline to be done. There is some certain concerns that the West Midlands raised in their 7th report that they said they felt was a continuation of what they'd seen in 2014. That has been taken on board by the department. There is being a management restructure. There are some posts that have disappeared, some posts that have merged. At the end of the day, my viewpoint is that a lot of what the West Midlands reports have identified has basically come down to communication. Of us not being very good at communicating either with patients or internally. I think it's a mixture of the two. And I'm again going to be very, very blunt and turn around and say, as a department, we have to get better at that. At the end of the day, we're dealing with people's health, and it's important that the lines of communication are perfect the whole way along.
Well, maybe we should look at that again in a minute, but there was a governance board set up in 2014, which again Malcolm Couch abolished in 2016.
I'm not convinced the governance board was working as it should, to be perfectly honest. I'm not sure it added any value. I mean, you know yourself, Roger, you can have committee after committee committee, and they can be great talking shops and talk about a lot, but if they're not actually delivering, what is the point? I've never been a great fan of having huge amounts of committees, because I think that's where you can end up with things very disjointed as well. And one of the things I'm very keen on with this department, it is a huge department, but we do need to be one unit and working together, breaking down the silos that are within the department, because as I said, there is an overlap between the different divisions. Particularly on mental health, for instance, we need to start treating people as individuals within the service.
Much duplication of effort?
I think in certain areas there is some duplication. And again, this comes down to efficiencies, where I think over time people have developed their own systems for doing things, not realising that potentially the same thing is being delivered in a slightly different way somewhere else within the department.
Comes back to the
And
communication, doesn't it?
And we do need to look at that. But particularly one of the things I'm keen with mental health and with health in general is that we treat people as individuals, because what you tend to find in mental health, for instance, is someone with mental health problems doesn't have just one particular problem. They may have an alcohol addiction, they may have a drug addiction, and we've been in the past very good at sort of treating the individual elements but not looking at the person as a whole. And I think that is where we've fallen down, and that's something I'm very keen that all the different elements of the department work together.
Well, next Tynwald agenda, which is my next Tynwald sitting, which is what, next Tuesday?
Next Tuesday.
The chairman of the Public Accounts Committee, which is Mr. Speaker, is going to move that his report on the overspending at Nobles Hospital is received and recommendations approved. And he set out a number of recommendations, 7 of them in all. One of them says the health department should focus on a single strategic document that outlines prioritised goals and service provision and budget. It then talks about a significant change programme such as integrated care, which is to a degree what you're talking about, or a shift to community care must be allocated. Services should not be expanded or new ones introduced until the department's back in financial balance. That didn't go down with the Council of Ministers.
It didn't go down well with me either, to be perfectly honest. I mean, in relation to that recommendation, Roger, I think the issue is that people are automatically assuming, and the Public Accounts Committee seems to be assuming, that any new service has to be what you probably call a loss-making service. So it's going to have a huge drain on the budget. That's not the case. We may well be introducing transformational services out in the community that could actually end up saving money because you're taking people out of the hospital, out of the acute side, which does cost a huge amount of money, and treating them in a community setting. So I think there's a bit of a fundamental flaw there in that it seems to suggest that any new services are going to be a loss leading.
The department needs to articulate a vision for its financial and non-financial management information. Well, it sounds to me as if that's what you're trying to do at the moment.
I mean, to be perfectly honest, a lot of the recommendations that have come forward, and you'll see from the Council of Ministers' response, are accepted. Right. There's very, very, very little other than that recommendation around not introducing new services that has been turned around and said we don't actually agree. A strategic plan and a 5-year budgeting plan, again, I think personally is quite sensible.
Well, I mentioned whether the model of finance was all right, and you seem to think it was, but recommendation 6 is they're recommending the Treasury examines how effective the current budget process is in supporting departments with their requirement to deliver the public services, which is another way of saying what I was saying, really.
Well, to be honest, I think Treasury does that every year anyway as part of the budget process. Certainly, obviously, I wasn't minister at the last budget round when the discussions were going on with Treasury, but I was within the Cabinet Office and I was involved in the discussions with Treasury about the Cabinet Office's budget, and personally I thought Treasury was very engaging with the departments and was very sympathetic to the department's needs.
Now, you're trying to do, coming back to more internal changes and methods here, programme to reduce staff numbers, which was November 2017. Now, we're talking 1 minute of needing to provide services and various other things, and then you're talking about cutting back the numbers of people within the department. So where was that number, where were they going to come out from?
A lot of that has come from middle to senior management posts. A lot of the people who've applied for the Mars scheme. And like I say, one of the things that has been identified by the West Midlands has been governance and communication between roles. And one of the things we have been looking at is the management structure, is the structure across the service too top heavy?
Okay, now let's just stop for a moment and for the benefit of our listeners, the word Mars might, that's a word which everybody maybe in your end understands, but I'm not too sure all the public might. Mutually agreed resignation scheme. Yeah. So in other words, you can take voluntary retirement early.
Well, voluntary redundancy, effectively.
Yeah, redundancy, is it? Right, yeah. Okay. Right. So, but you to say the management's grades, basically middle management particularly, and there's a lot of talk about non-essential roles. One has to ask the question, if they're non-essential, what were they doing there in the first place?
Well, that was something I queried as a backbencher, to be perfectly honest, Roger. You might remember I had a question down at one point. I can't remember whether it was back end of last year or the year before, where I did actually ask what the definition was of non-essential, and I didn't seem to get an answer. From my point of view, what's important is that we have a streamlined system. I think sometimes the problem has been, again, that a lot of these structures have developed over 15, 20, 30 years, and nobody's ever taken an opportunity to step back and say, is this delivering what we need? Because at the end of the day, everything that we do within the Department of Health and Social Care should be driven by providing a service for our service users. We don't exist in order to exist, if that makes sense. We are there to actually deliver something, to deliver front-end services. So every role that we have within the department should be adding some value somewhere down the line to those front-end services.
Well, you say we don't exist in order to exist, but it's almost a yes minister joke, and I've seen it in operation. A great deal of at times administration people think that their interests are the interests of the public, but they can't separate the two. I've seen that happen on a number of occasions, and that's why sometimes departments build in numbers and why various duties seem to appear. I mean, when you're cutting back the middle management grade, one assumes they did something. So who's going to do the work they did?
Well, the work is being picked up in other areas. I mean, this hasn't just been a case of deciding you over there, you should go, you over there, you should stay. It has been a case of looking at the workloads, and times change, to be perfectly honest, and we shouldn't be scared of changing structures to fit in with those times. We have the digital strategy coming online that is delivering real savings across the department, for instance, in relation to patient records, where the digitisation programme is now nearly complete. That takes out a whole work stream of where paper records had to be delivered around the hospital, etc. There's various things like that, and we should be updating the structures within the department in line with the changes. In the past, again, I'll be honest, brutally honest, I don't think that's always happened.
Well, I am aware at the moment from a personal experience that information on one system can't be picked up by somebody on another one.
And that is something else that's currently being looked at. For instance, one of the things that the West Midlands Review, the 7th report that we've already been speaking about, picked up is that in one area they were using 6 different IT systems. The West Midlands Review quite rightly focused in and said there was attempts to change that and focus on using mainly the Medway system. But one of the things we do have to do is look around the department and make sure that any technology we have is able to interact with one another. I think that's a legacy thing. You find it not just in the public service. I know from the private sector, I mean, I'm a project manager by trade. I've seen many, many occasions, even in private sector firms, where you've got multiple IT systems and one can't talk to another. So it's very important when you do design IT systems that they are open architecture and can communicate with one another.
I'm curious, though. I have a small business with 10 staff, and at times they have difficulty in communicating with each other. How are you going to get 3,500 people to do that?
I think the key thing is it's culture change. It's making sure that people feel they're part of a larger organisation. I mean, it's all very well, feeling, yes, I'm part of the hospital, I'm part of the Children's and Families Division, I'm part of the Mental Health Division. But what you need to do is embed a culture whereby, it's not all silos. You're not just in your box, and that things that people are doing elsewhere can affect your work, and that it's important that you do speak to them and communicate. And again, it's putting the patient or the service user first.
I'm not challenged. I'm just curious on how you're going to achieve it with 3,000 people, many of whom will be set in their ways.
Many people will, and again, from my experience in the private sector as a project manager, my role was permanently trying to get people to change and adapt, and it is hard to do. As a species, we do actually resist change. We like things as they are, but I think what we need to do is listen to the staff as well. The staff within the department on the ground are delivering these services day in, day out, and the work that they are doing is invaluable. And there is frustrations out there as well amongst the staff. I'm not going to hide away from that, where they feel themselves things can improve and things can be done better. And what's important is we are a department that listens to the people who are delivering the services, because they're the people who know best how to change. I'm not going to sit here and claim I know perfectly how to deliver a mental health service, how to deliver a children and families division. I need to listen to the people who are delivering that services and try and help them do the job that they're doing.
How do you listen to the patients, the public, the people who are using your services?
Well, one of the things that I'm going to be doing over the next couple of weeks is going out and about speaking to staff within all the divisions, trying to understand where they feel things can be improved, where they've got frustrations. Obviously, we're not going to change the world overnight. I'm not stupid enough to believe that. But I think it is important that people feel that they're engaged in the process and that they have something to input, because they are the people on the ground who day in, day out are trying to deliver the best service they can to the people of the Isle of Man.
Do you think people in those roles sometimes are prepared to stick their heads above the parapet and tell you what they really think?
Well, I'm hoping they will, because that's the culture I want to embed. I don't want to hear, all the fluffy stuff and that everything is rosy in the garden and everything's fine. I want people to be honest with me, and that includes members of staff throughout the department. That if they feel something isn't right or something can be done better, that they're willing to say so. Sometimes there may be a very legitimate reason why you can't change something. It may be a legislative reason that you've got to legally do it that way. But again, it comes down to communication. And if people have ideas that can't be progressed, it's important we go back and explain to them why.
I have to say, from my own experience of various sections of the hospital, that I have not got, despite what I hear from other people, not one grumble. Everything I have received, and I have to say this, has been actually spot on, with no cause for a grumble, except when it comes to the paperwork.
Yeah, and again, digital strategy kicks in there. I think there's more we can do digitally around emails for people. Most people are on email now. There's still a huge volume of letters that I see going out into the post to people. I want to start looking to see, is there a way that we can collate email addresses for patients and things go out via email, we already have a text system in certain areas of the service, to expand that as well, so that less paper is flooding around the system.
I have had situations where I have been told I missed an appointment I was never given. I've had appointments for a consultation that arrived through my letterbox a fortnight after I was meant to be there. I've had it arrive on the morning I was meant to be there, which is an hour's time hence. And recently I received 2 separate appointments, same time, same date, in 2 separate envelopes a week apart.
Exactly, and that's why, like I say, I'm a great fan of digitisation, because a lot of that removes user error in the system. We are a large department, the health service is massive, and there is a huge amount of correspondence going out, and unfortunately there have been instances I know of from constituents as well where issues like that have occurred.
Well, the cost seems to be, when we look at the cost, there's the cost of the basic staff, and we have an issue maybe we could talk about later about where you're going to get the staff from, because that turns out not to be easy anywhere in the British Isles at the moment, not just the Isle of Man. But you're therefore having to fill the gaps with locums and agency staff. And that's where the considerable cost is coming in. You're not going to be able to do much about that at the moment, are you?
Well, actually there is. There's work streams already underway. One of the things that one of the problems we've had in the past is a lot of the disciplines around the health service we've been operating on a one consultant basis. So if that consultant goes off ill or goes on holiday, the work's still got to be done, and we're having to bring in locums. What we're trying to do is reduce our exposure to a single consultant basis. So we are trying to recruit additional consultants in certain areas, which reduces our locum spend. The locum spend that you referred to has actually been falling over the last 3 years. So there has been work to bring that down. There's a lot of work still to do to bring it down even further. I'm not going to shy away from that.
Does that even mean that you are bringing it down because you're covering, or you're just not using so many of them and waiting times are increasing?
No, I think it's because it's a mixture of the two, to be honest. Most waiting times, which are now published online, of course, whereas they weren't previously, most waiting times are fairly decent. There are some services that are under pressure, and again, I'm not going to shy away from that, where the waiting times could be better. But in relation to the use of locums, we are making concerted efforts to bring that down and moving away from a single consultant basis in a lot of the specialities.
There is a public perception, rightly or wrongly, that this circumstance, this situation would improve greatly if a lot of the consultants didn't do so much private work.
Well, I mean, that's something that's set up since the NHS was, again, founded in 1948 in the UK, where there was the deal with consultants that they could do private work. I think we've got to recognise that on Ireland we are a small jurisdiction, and I would worry that if we turn around and tried to say you're going to have to be 90% NHS or 100% NHS, why would the consultants wish to work here?
Well, there may be other reasons, of course. It depends on what role they take, doesn't it, and what incentives. But, well, this takes me to... we're talking about additional staff there, in effect, but it's quite well known you have to have additional staff at the TT. Where do they come from?
Well, we pull in additional staff. There is people out there who can use bank staff, etc., for the TT. So you don't want that number of staff all year round because there isn't the demand there. So there is a list of staff that can be called in over TT periods and peak periods in terms of the bank. In relation to recruitment of staff in general, which you've referred to there, Roger, I think that ties in to the modernisation of our health service over here. I think we've got a huge opportunity to really have a transformational health service. And I think if we can deliver an truly integrated health service where other jurisdictions have failed, I think you solve your staffing problem because you become a shining star where people want to come and work in the Isle of Man Health Service. And I think that's what we need to do. We are a small jurisdiction with a population of about 84,000. We should be looking to aim to be a transformational service and not just follow the models in other jurisdictions, but do what's right for us.
Sounds exactly right, because I often argue that we'd make far too many comparisons with the United Kingdom and the standards, which not necessarily exactly fit the bill over here. But this is two issues here. One is, of course, an administrative one. The other is a political one, and the political will, which that's what the minister is there for, and that's what, therefore, you're there for. But it's quite well known that ministers very often don't stay in jobs all that long, and you've got, 3.5 years to go at this stage. You're not going to get this done in 3.5 years, are you?
I think, not everything is going to be achieved in 3.5 years. Again, I'm not naive enough to think that. A lot of what we need to deliver, as the Chief Minister said the other day around the substance misuse strategy, it takes time. It takes years, not weeks or months. But I think we can, during the time I am Minister, however long that's for, set a direction of travel. And I think one of the bonuses of our political system, that it is generally independence rather than political parties. You don't have the same upheaval as in some other jurisdictions with political parties, where they've got a completely different philosophy. They come in and they upend the entire thing and start from scratch again. I think we've got a huge opportunity that if we are setting a direction of travel that is right, that whoever comes after me can continue down that road of delivery.
Okay, well, we'll pause our conversation, David, at this point.
Manx Radio.
The operation, financing and future of the Isle of Man Health Service is the topic for discussion in this week's Sunday Opinion. And our studio guest is the Minister for Health and Social Care, MHK David Ashford. Now, you may have noticed we haven't talked much about social care so far, and I think you will find in this programme now there will be, because both of these subjects are really, I think you would agree with me, David, a programme on their own, if not more.
They most certainly are. In fact, as we were just discussing during the break there, Roger, I think each of the divisions within the department could be a programme in its own right. In terms of children's and families, mental health, yes, public health, and obviously what we're discussing today, the health service in general.
We have actually had public health as a separate programme, so yes, and you're quite right, it was a completely separate programme on its own. We talked about the cost of labour, particularly the cost of locums and agency staff, but the other fundamentally heavy, ongoing and unpredictable cost of the health service is the cost of drugs. Now, I don't know how the Isle of Man compares to the UK, but there was recently an article came out and said in the UK prescriptions of 1.1 billion a year. Now, if we bring that back to Isle of Man's stage, still many hundreds of thousands of prescriptions. They're saying that maybe some of them are just routine things like anti-cholesterol, blood pressure, painkillers and reflux things. But have we had much of a cutback, for instance, on our prescriptions of medicines over the counter that you can get, like paracetamol or cough medicine?
Well, again, this is something I do want to take a look at, is the amount of drugs being prescribed and what is being prescribed, particularly around aspirin and paracetamol, the things that you can generally pick up quite cheap in your local store. In terms of prescriptions, as you will be aware, one of my first acts as Minister was to stop the changes that were going to happen in relation to prescriptions,
charges.
where there was going to be, where the age at which you got free prescriptions were going to be linked to when you got a free TV licence at the age of 75, which personally I found quite ludicrous, and also the fact that we were going to slash and burn the exemptions. I just felt at the time that that wasn't right, and that we would have been victimising some very vulnerable people who would have then found it very difficult and potentially have caused us further costs down the line by not seeking the drugs that they do need. A couple of figures I can just throw at you, Roger, in terms of drugs bills, and this is just the figures from Nobles Hospital. In the last year, it's expected that the drugs bill will be 7.2 million, which is 1.4 million over budget, and almost £1 million.
This is not
so
the
this
GPs.
is this is just the hospital. So that gives you a flavour.
Yeah.
But again, I think one of the things that we need to do is, if we stop being a sickness service and start moving towards being a wellness service, if we catch things early enough, that automatically brings down your treatment costs, and we need to be pushing more for a service that is based on early intervention, not stepping in towards the end when someone is ill and their condition has worsened.
Yeah, I knew a woman once who was a Chinese woman who was a Chinese doctor, and she said, although it has changed a bit now, there was a time her father was a doctor too, and she said that doctors got paid when the patient was well and they didn't get paid when they were sick. Which is a sort of logic that you're saying, isn't it?
It's an interesting suggestion anyway, Roger.
But how can you anticipate demand with drugs, for instance? You've no idea what's going to come through the door of the hospital next, and some of the drugs, as far as I can see, are an absolute fortune.
I mean, again, it's demand-led, and it is one of the problems of a demand-led service. You can't predict from one year to the next what people are going to suffer from, and equally you can't turn someone away saying you haven't got the right condition, come back when you've got something different. It doesn't work like that. But I think one of the things that you can do is, we do see patterns. We know what our drugs bills have been over the last few years. We know where we're seeing spikes in demand in different types of medicines, and we should be getting better at collating data and being able to try and predict those trends.
The UK comparisons and we talked about making UK comparisons, but the Isle of Man comparisons with the UK, to a certain degree, hold good, don't they? Because you buy your drugs basically through their purchasing system.
We do, and it does hold good to a certain extent, but equally we have a better system in place than the UK in terms of the cost of drugs. In the case of the UK, there was recently a news story, and I did an interview with John Moss about this, where it turned out there was prescriptions being fired out that were tens of thousands of pounds at a go. Over here we have much tighter control, and there is exception reporting that's a lot better, so that if doctors are prescribing something that is over a threshold, it does need to be reported with the reasons why. So we have a lot tighter control than they do in the UK, where I think it's a lot easier for their budget to run completely out of control.
Do you do your best to buy generic drugs as opposed to the brand names?
Yeah, I mean, obviously different people require different drugs. We're all unique as individuals, and some people react differently to different medication. So it is important it's the right medication for the right person. But if there is a cheaper alternative that does what it says on the tin, then obviously that's what we should be looking at.
The trouble with a lot of drugs, new ones that are on the market at the moment, are new and effective ones, they're still under license to the manufacturer. And that's where the cost comes in, indeed, doesn't it? I found it amazing to see a remark, and I didn't know, looking at it, wondered, well, it was a misprint when I first looked at it. It said that the flu vaccine, which everyone's encouraged to take if you're over a certain age, costs £4,300 a go.
The flu vaccine actually changes year on year. One of the things I've learnt since I became health minister, actually, like I say, it is a job and you're learning quite a lot, is I didn't realise myself that the makeup of the vaccine actually changes every year, because what they do is, there's so many different strains of flu, they try to anticipate which ones are going to be the major developers over the forthcoming year, and it's to try and combat those strains within the particular injection.
But the 4,300 is right then.
But it is a costly process. I wouldn't say it was 4,300. I'm not sure what the figure is, to be perfectly honest. But I certainly know it is a costly process.
I picked that up on one of your department's handouts, actually. So that's why I was wondering whether it was a misprint in the first case.
Yeah, but it is a costly vaccine.
So we have the health service that's running still running on the old principles anyway, back to the days of Beveridge, back to the 1940s. But there are changes afoot, we hear. Cannon refused to rule out the possibility of introducing NHS charges after calls were made for the service to remain free only quite recently. And privatisation, Mr. Cretton was extremely worried about this. It had a Tynwald report. And it's been suggested that perhaps we will have to go to a separate health tax or increase to the NI. In fact, the UK is looking to put a penny on the NI contribution.
I'll be perfectly blunt here, Roger. I think there's an awful lot of scaremongering out there where people are absolutely determined, no matter how many times it is said that the NHS is going to be protected, we are still going to have a service that delivers things free at the point of delivery, that as soon as people hear the word review, they suddenly think privatisation. Well, to my mind, that is absolute nonsense. What we have to do, and what the Treasury Minister has made absolutely clear, as has the Chief Minister, is we need to have a proper review of what we are delivering and how we are delivering it. Nobody is talking about decimating the NHS, which is what a few people seem absolutely determined to get that mantra out there. It's not true. It's not correct. For instance, but you mentioned there about free at the point of delivery, and I mean, that was one of the principles laid out by Owen Bevan on the 5th of July 1948 when he launched the health service. But what's intriguing is if you go, even back then, when they were talking about free at the point of delivery, if you go to the NHS Act of 1946, there were exemptions to that. There was the ability to charge for children under the age of under school age. There was the ability to charge for pregnant women. There was the ability to charge pregnant women for dental care, for children for dental care. And none of that to be free. And equally, if you needed equipment, say for instance a wheelchair, and your needs outstripped what the health services standard wheelchair was, you had to pay for it. And we're not talking pay the difference, you paid for the whole thing. So even back in 1948, what was free at the point of delivery has been constantly changing and evolving. The list I just gave there, if I came on the show today and announced that was the route we were going to take, there would be outrage. You'd probably have the biggest phone into Manning line in your history. But think about it. That was what was there in 1948. And even the Labour government under Attlee, Bevan, of course, resigned over this, was they stopped giving out glasses free. They stopped giving specs free because of the demand that was based on the service. What we've got to do is design a health service that is fit for 2048, not keep looking back to 1948.
Well, you suggested they came up with the funding first and then made the service to fit it. But that, of course, means that you only then provide what you can pay for.
Well, that's what I suggested historically has always happened. What I've actually said about this review is we need to be starting with a blank piece of paper, and what we need to do is decide what do we need to deliver, then how do we need to deliver it, and then what is the funding model. What I was saying in those couple of interviews that I did not long after I became minister was in the past it's always been the wrong way around. We've had a funding model and then tried to fit the services into that funding model. And I think one of the great things about this review is it is a huge opportunity to get it the right way round and look at the services we're delivering first and then look at how the funding model feeds in.
But maybe the best people to help you to do this are actually the medical profession.
Well, again, they're going to be fully involved within the review. Again, there seems to be this doom-mongering going out there that this is going to be a review team that's going to sweep in, tell us everything's wrong, tell us to change everything. That's not the case. As I've said before, we have a 5-year health strategy. We should be working towards delivering that strategy. That work should be ongoing. And we should be seeing this review as being helpful in delivering that strategy and ensuring that we have a proper healthcare system for the people of the Isle of Man and a transformational healthcare system as well. And obviously, in order to do that, we will have to engage with the medical professionals.
Are we coming right at the start of the introduction? The original Act said to provide the facilities or have provided, in other words, to source it. Is there any likelihood that parts of the NHS are going to be privatised?
Look, again, this is scaremongering, I'm afraid. That there are people going out and saying privatisation. What I can't seem to get out of anyone is what is their definition of privatisation. So, for instance, general practitioners, your doctors, they've been effectively privatised from day one. they operate on a commission basis.
Well, David, I'll have to interrupt you there, but I gather you're coming back to join us on the Man in Line.
I am indeed.
Right. At this point, as you may gather, then we must end the Man in Line. Sunday Opinion. We'll be back for the Man in Line, in which we've been exploring the operation, financing and future of the Isle of Man Health Services with the Minister of Health and Social Care, MHK David Ashford. We'll both be back at 1:15.